Welcome to those at home. We welcome you to your virtual classroom here. We want to engage both you and our viewers in person here as much as possible, but due to the length of our presentation, we'd like to hold any questions until the end of the presentation, and we'll help facilitate that process. At home, please get familiar with the chat feature. This is how you will have access to the handouts as well as a copy of the presentation that will be given. You'll have access through the chat feature. That's also how you will be able to pose your questions that I will help moderate for you here live with our speaker later on. At the end, you will also be given a link to the survey via the chat feature, and so we would really appreciate all of your feedback after the presentation. So I encourage you to stay connected and complete that survey. And in person, we'll hand out those surveys on paper. So now I'd like to go over a lot of the great work that we're doing, and I'm really excited to be able to share this information with you. So this is our manifesto, and it really explains what we are all about. It's our statement of beliefs. And so now I want to talk a little bit about why we created this foundation and what our manifesto really means. There are 28 million cancer survivors around the world today. We know that cancer touches everyone. We began the foundation in 1997 so that we could serve survivors, their families, their friends, their caregivers, and their healthcare professionals. In 2010, cancer became the leading cause of death worldwide, killing more people than HIV, AIDS, tuberculosis, and malaria combined. These are numbers, they're statistics, but behind every number, we know that there is an individual and a story, and we are determined to ease the burden that cancer has on the people in the United States and around the globe. This is our headquarters. We are based in Austin, Texas, and we chose the location of our headquarters in East Austin, which is locally a traditionally underserved neighborhood, and we wanted to be able to have the greatest impact with our services by being nearest to the folks who need them most. This is our mission. Simple. It's our singular purpose. We don't believe in doing things the way they've always been done. That means we make partnerships with media companies and sporting parks, and it means we advocate for policy change to leaders at every level of government. We are impatient. We cannot wait for a cure, and we are about taking action today to help people affected by cancer. And the great news is there's a lot that we can do and that we are doing, so I want to now take you through how we are helping survivors. First, we provide direct, one-on-one, free and confidential support for anyone affected by cancer, someone who's been diagnosed, their family, friends, caregivers, and health professionals. If anyone you know who needs help dealing with cancer, share our website with them, livestrong.org/get-help. So how do we provide this service? Our primary mechanism for doing this is via our navigation services. So what do we mean by navigation? We mean helping people maneuver through the healthcare system, treatment and insurance questions, emotional issues, and any other concerns that come up when dealing with cancer. We provide support, information, and resources to anybody affected by cancer, and these services are available in English and Spanish, by phone, online, and in person. At LiveStrong, we believe survivors should have everything they need to make a well-informed decision throughout their cancer journey. That's why we created the LiveStrong Guidebook. It's designed to help survivors address their physical, emotional, and practical concerns by providing information about all cancer types, treatment options, finding the best healthcare resources and support services, understanding insurance and financial issues, and much more. These copies are available online at livestrong.org/guidebook, as well as by contacting our navigation services. Our newest tool is the LiveStrong Cancer Guide and Tracker app for the iPad. It combines all the information and journaling opportunities of our printed guidebook with helpful online functionality. Unique features include a symptom tracker and tools to help organize appointments, finances, treatment information, and medications. LiveStrong will continue to enhance this Cancer Guide and Tracker app to help improve quality of care, engage patients in clinical decisions, and facilitate research. In addition, we provide cancer support within communities too. An example of this is LiveStrong at the YMCA, which is a way that we help support adult survivors in the transitional period after completing their cancer treatment. It takes place at the Y and outside of medical facilities because our focus is on health, not disease. The goal is to help participants build muscle mass and strength while increasing flexibility and endurance. The free program also provides a supportive environment and a community among participants, YMCA staff, and other members. LiveStrong at the Y is now offered in more than 100 YMCAs in 40 cities, allowing more survivors to receive free help in their communities. You can participate in your neighborhood, nationally or globally. In your community, you can find other LiveStrong supporters who raise awareness and funds to fight cancer. You can host an event or participate in one that's already existed. You can join Team LiveStrong and participate in athletic events across the U.S. You can follow us online to discover more ways to take action, too. You can give a gift to support people affected by cancer, and you can learn more about these opportunities and others by visiting our website, livestrong.org/takeaction. Team LiveStrong is a way that members don't have to live in the same city or compete in the same event, but everyone is still on the same team. We participate in walks, runs, rides, and triathlons. In 2011, over 12,000 Team LiveStrong athletes participated in events around the globe and raised over $82 million for the foundation. To learn more or to join the team, check out teamlivestrong.org. Advocacy is another way to take action. LiveStrong fights for policy initiatives to help people affected by cancer on the state, national, and international levels. For instance, we have promoted smoke-free legislation in Texas and California, and we have met with leaders in the U.S. government to fight for cancer funding during budget negotiations. We are also working to bring cancer to the forefront globally. If there's one thing to remember, it's that no one has to be alone when dealing with cancer. You can always contact LiveStrong by phone, online, or in person, and we want to connect people to existing services and resources. That's why we are here. There are many ways to take action. You can do this by connecting people to support that they need and empowering them to take action in the fight against cancer. I hope you've learned a little bit more about what we do here at LiveStrong. And now I'd like to take the opportunity to introduce our speaker for the evening, Mr. Brendan Beatry. Brendan is currently a bilingual case manager with LiveStrong Cancer Navigation Center. He responds to patient referrals involving access to health care and financial matters relative to cancer in Central Texas and nationwide. He does this by being an active liaison between the patient and their insurer, employer, and/or creditor to resolve insurance, job discrimination, and/or debt crisis matters relative to their chronic, life-threatening, or debilitating illness. And I'd like you to join me in welcoming Brendan up to the front.
Thanks so much, Emily. Well, like she said, I'm a senior case manager with the Patient Advocate Foundation and financial navigator here at the LiveStrong Cancer Navigation Center. The purpose of the presentation is really to inform and best prepare both our local audience here in Austin, Texas, and our national audience viewing from home. Thank you so much to both of you for attending. For the obstacles in the way of access to care and also to inform of the gaps and safety nets in place in our current healthcare system, and to safeguard against the financial challenges or ramifications of cancer. We have about 45 minutes to cover what we need to cover, and throughout the presentation we'll show a short video on healthcare reform that should give us some kind of mental recess from the information that's rather dense but entirely important that we'll go through. And then we'll open up for open discussion, and feel free to jot down questions you have throughout the presentation, and definitely speak as freely as you feel comfortable about your own personal situations and those of friends and family. We could quite literally spend an entire day on this subject, so we're going to just give you a broad overview, and during the Q&A dive a little deeper into scenarios you may have, issues that come up, very detailed questions you may have regarding yourselves, your own fights, or those of your friends and family. I should have given you in your slide deck a list of objectives that you can refer to throughout the presentation that will let you know what we plan to accomplish and learn today, and we'll start now. Okay, so I just wanted to briefly go over our mission with Patient Advocate Foundation. We seek to safeguard patients through effective mediation, assuring access to care, maintenance of employment, and preservation of their financial stability relative to their diagnosis of life-threatening and debilitating illnesses. I would say about 80% of the folks who contact us have some form of cancer. And since 1996, we provided this kind of direct ongoing assistance to more than 500,000 patients nationwide. Here's a list of our direct services that we provide. At top, we broker or network resources to supplement the limits of insurance and assure access to care for the uninsured. We'll go directly into how we do a program that we offer, copay relief, a little later in the presentation. We also resolve debt crisis relative to a diagnosis, and in large part this is really non-medical debt. As cancer strikes, patients and families may suffer a loss of income. The sheer cost of care may be a financial hardship for the family, so much so that it might force them to make the decision to cover their basic necessities and household bills over making do with the cost and their out-of-pocket responsibility for their medical care. We also negotiate access to pharmaceutical agents, chemotherapy, medical devices, and surgical procedures. We resolve insurance issues in the public and private sector. We negotiate pre-authorization approvals. Services that may require that kind of pre-authorization might include a bone marrow or stem cell transplant, a PET scan, an experimental surgery, etc. So we communicate with the doctor's office to make sure that, that those authorizations take place. We also provide assistance in facilitating and expediting the appeals process. Now, we won't go into depth about health insurance denials. That would take another hour and a half that we really don't have at the moment. But that we do, it suffices to say that we have staff that will help a patient draft an appeal to obtain or overturn a denial of coverage for a specific service. As many of us may have found out, insurers do like to deny services on the basis that they don't believe they're medically necessary, or that they're experimental or investigational, and many other reasons that they use to deny. So we will draft an appeal for the patient and put together the best possible argument to secure coverage for them. Now, Social Security disability is a process that we'll go through a little later, so I won't spend so much time. And we also have billing and coding experts who are certified and licensed to help with those sorts of issues. And really my role and the role of the case manager is to work as a liaison, as Emily had mentioned, or an intermediary between the patient and the hospital, between the patient and the pharmaceutical company, between the patient and the government office, between the patient and his or her landlord, a utility company, just to kind of resolve these kinds of issues. And we do this primarily via conference call. And so our intent is to be proactive and to resolve some of these issues that are otherwise not manageable by the patient and family, alone. Okay, if we talk about the uninsured, those who do not benefit from employer-sponsored coverage, individual insurance in the private sector, or Medicare, these are the kinds of options that are available. And again, my role as a case manager is to identify those programs and benefits that are available to patients based on their income, based on the phase in their treatment, based on their diagnosis perhaps, and then to accelerate the process, to try to speed up this process to get them qualified for a county indigent program, to get them qualified for a sliding scale discount through their community hospital. These are negotiations that we can do as a third party on behalf of you all. I'll go ahead and speak a bit about Medicaid in the next slide or a couple slides from now. There are different categories of Medicaid. SSI linked, which is a Social Security benefit that folks who are sufficiently disabled will qualify for, and therefore qualify for Medicaid simultaneously. There are programs, not in the state of Texas, but in other states, that will allow an otherwise eligible person with a slightly higher income to pay a share of cost, or let's say a monthly premium, and still be eligible for Medicaid. There's also a Medicaid for folks diagnosed with breast and cervical cancer, and in some other areas of the country, other cancers are covered by their state Medicaid. For those who are perhaps elderly or of Medicare age, there are Medicare savings programs to help them with what traditional Medicare does not cover, and those are really bound by the patient's income. And then below, for the uninsured, this may not be so commonly known, or people may not be aware of this, but there are pharmaceutical treatments and drugs and durable medical supplies that are recommended by physicians that are readily available through the manufacturers. They do offer, and there are income guidelines around this, but if you just jot down a very important website that I use almost daily, needymeds.org, it houses a very long list of programs for the uninsured to get you to obtain you access to pharmaceuticals. And it's not only cancer-related medications and supplies, also diabetes testing supplies, for example, cardiac medications, diuretics, blood thinners, nutritional supplements, that kind of thing. So it's very useful. At any phase in your treatment, I would really urge you to utilize your hospital support staff. I can't stress this enough. As early as possible, let's say you're newly diagnosed and your first point of entry into the system is the emergency room, or a community hospital, or a community clinic. You want to always talk with a financial counselor at the onset of your illness, even when you're diagnosed, or a nurse if there's no such thing as a financial counselor available to you. These people have a real keen sense of the community resources and internal funds that are available within the hospital, within the health system, that might offset or be able to absorb some of the costs that you would otherwise have to pay out of pocket. And if you receive a bill, please don't ignore it. Do your best not to ignore it. Even though hospitals would rather not do this, they will at times send a bill to an external collection agency. If it's not paid, or sometimes you only need to call and address it over the phone and make them aware that you're ready and willing to make a good faith payment over time toward that account. Some hospitals, like I mentioned, have charity care or uncompensated care funds that they use to absorb costs that a family on a limited income would not otherwise be able to manage. And if you do have accounts in collections, you want to know your rights under the Fair Debt Collections Act. It will, certain collection agencies are regulated and they're not allowed to harass a patient and family excessively. There's a certain number of calls and notices that they're allowed to issue, so don't allow them to kind of push you around and pressure you. And there's a link there to the Fair Debt Collections Act. Medicaid, like I mentioned before, is a state benefit. It's a government-sponsored benefit that varies from state to state. The benefits and eligibility vary. To be eligible for Medicaid, if you're an adult from the age of 19 to 64, you will very likely need a determination from Social Security that you're sufficiently disabled, and then be below a certain income threshold or guideline that they establish. But other than that, once you're approved, it covers hospital care, physician's fees, prescription drugs, home care, and those benefits vary definitely from state to state. It's only valid in the state in which you reside, so you can't typically go outside of your state on your Medicaid benefit and pursue care in Los Angeles, or if you're a Texas resident, or Jacksonville, Florida, or other parts. And you can find an application at your local Department of Social Services. Okay, for those people who are employed or self-employed, many times with cancer, you may not feel well enough to maintain your current work activity, or perhaps because of a layoff or because of your disability, you have to rely on certain provisions to maintain your insurance. Now, the first two provisions here are federal ones. The COBRA up top is an acronym for a very long term that I don't dare pronounce or remember. But it's essentially a group policy extension that allows someone who's been laid off or had to stop working due to a disability. It allows you to maintain that insurance at a premium payment that you would have to come up with. So it's 100% premium that you would have to pay. And later on, I'll let you know of a few organizations that do actually offer assistance with that premium in some cases. Okay. And so HIPAA Portability, that's another acronym that's more commonly associated with the privacy and confidentiality of patient information, but it also applies to, it's also a guarantee that certain individuals can maintain and renew their insurance as they make their way from one employer to the next, or from a group plan to an individual insurance plan. And also for those folks after their 18th month of COBRA, that's an option for them to transition into a HIPAA policy. And the one at the bottom is a state provision. In the state of Texas, for example, if you own a restaurant with your spouse and your 24-year-old child, and so you're a group of three, a business of three, you can actually apply for insurance without being underwritten so severely as a group. It's called Group of Two, and you can actually go to statehealthfacts.org to kind of see how that guaranteed issue provision works in the state in which you reside. Okay, medical expenses and tax deductions. So it's the 25th of April. We're 10 days after the standard deadline to declare your taxes. However, if you've been granted an extension and have not accounted for any medical costs that are still outstanding or have already come from your budget out of your own pocket, you can declare them. And the amount that you can declare in this example is 7.5% of your annual adjusted gross income. So if you're a family with $30,000 annual dollars coming in, you can deduct any amount over $2,250. You can print down a publication to attach to your tax return, and that's how it works. So it's not only medical costs too. I want to kind of stress that. It can be doctor's bills, drugs, medical supplies, etc. But it can also include dental cost, vision, and also transportation and lodging that's related to your medical care. And that could be for any one of your dependents, for your spouse, or any of the dependents that you would declare annually. Okay, so the Social Security disability process is a rather long one. It's rather lengthy, it's rather laborious. So we're going to go over in the next 3 slides. For those of you viewing at home, I believe this is slide 10. So the Social Security system evaluates disability on the basis of the following factors: the age of the individual, his or her education, work background or profession, and disability, and they define that by the inability to perform gainful work activity. It requires that the applicant be unable to perform this work activity for at least 12 months from the onset of their disability. Okay. The link in the middle, ssa.gov/disability/professionals/bluebook, will give the layman or everyday person an idea of how they evaluate and approve disability based on your condition, be it a cancer, be it an autoimmune disorder, be it diabetes, be it a cardiac condition. You can go to this link and you'll find out really in the simplest terms if you qualify for disability. And this is what I use when I work with patients to, and also with doctor offices to inform them that this is the pathology, this is the prognosis that is needed in order for, and it needs to be assessed and detailed, in a very precise way, in order for your patient to be approved. And these are benefits that you've been paying into the system for quite some time, obviously. I want to stress that this is different than your short-term and long-term disability benefits that you may have through work. And also, at the very end, there are a number of conditions, medical conditions, that qualify for fast-track processing. So you want to go to the link below and check to see if either yourself or a family member has this very condition, because this is a recent change and it's a very positive one, because it will accelerate the process for those folks who are diagnosed with very grave, very severe illnesses. And so the next couple slides kind of go through the process. I'll try to kind of slow this down a bit for Social Security. The first step is to go to your local Social Security office in person or over the phone or online and apply. It takes about 45 minutes to an hour and a half, depending on kind of the length of your medical history, the number of providers that you're involved with, the number of doctors on your team. And that's something that we as case managers at Patient Advocate Foundation can help you with personally. It's quite a frustrating process. I do want to be frank about that. And then after the initial application, you'll have a phone interview where your local office will do a non-medical eligibility check. They'll check your work credits to make sure that you have enough to qualify for this benefit that you've been paying all your life into, your age, your marital status, etc. At that point, if you qualify after the first screening, they'll send your case off to a regional office. We call it DDS office, or Disability Determination Services. The most local office for our local audience here is in Austin, and you can Google it, or I'd be happy to give it to you after the presentation. And the timeline for evaluation, we talked about those cases that do qualify for expedited or accelerated processing, and that should take between 8 to 10 days from the date of application. And as case managers, again, we can help you to hold the Social Security system accountable for this timeline. It's very important. The standard processing for conditions that don't qualify for fast track approval is about 4 to 6 months. If it's denied the first time around, and I want to tell you that 60% of all first-time applicants are denied, our advice is to appeal that original denial, not to let time pass and then reapply at some later time in the road. It's always good to appeal. You can reconsider. So after the first denial, you can file for reconsideration, or in some states, for those viewing at home, you can actually skip this level and go directly to a hearing with an administrative law judge. I wouldn't so much suggest that you do that. The reconsideration level allows the patient to gather medical records that are missing perhaps from doctors that haven't supplied them or haven't really given you a very detailed assessment of your overall disability. It's a chance for you to kind of, and you can do this yourself. You can even gather these records and submit a very simple reconsideration. Now, if that level is denied, the appellant can either hire a disability attorney. You may see on the TV the commercial Binder and Bender, the guys with the cowboy hats, and so they're on hire, but it's not necessary. You can also hire a case manager, anyone that you would appoint as a representative to take on your case, someone who might be trained, for example, a case manager at our foundation. Okay, so Medicare is tied to the Social Security process, and it's somewhat of a misconception that you can apply for Medicare. I want to let you know that the only folks really that are eligible for Medicare are those who turn 65 and can opt into that benefit, or those who have been receiving Social Security for at least 24 months, well, for 24 months, are eligible automatically. And Medicare, as we know, provides inpatient care, outpatient care, prescription drugs, all of that. And you can call Medicare if you'd like to learn more about those benefits, or just simply visit them online. Okay, so now I want to talk a little bit about the underinsured. Now, that's kind of an emerging population in this here and now. In fact, 62% of the patients who contacted our foundation last year were fully insured, but that because of their out-of-pocket costs, responsibilities, they just could not make ends meet. The financial challenges were very burdensome, and they weren't able to really keep their household stable and put food on the table for their family. So this is these are some tips on how to manage the costs of care if you're insured through your work, or otherwise through the individual market. There is copayment assistance available, and we'll talk a little bit more about what we offer directly and how to apply for that. And that's really available for those who are insured by Medicare and insured privately. And these are disease-specific funds, so it's not available to everyone. It's really dependent on your diagnosis. Also, like I mentioned earlier, there is premium assistance available through a number of organizations that seems to be dwindling. Among them, Healthwell Foundation and the Leukemia and Lymphoma Society. So you can jot down those sites. Also, below that, under disease-specific charities, these are foundations that you may find are in existence locally or regionally or nationally, that can help you primarily with other expenses you may need to cover, such as mortgage, your mortgage payment, your rent payment, child care, transportation, a utility payment, those sorts of things. These charities are very largely diagnosis specific and usually need-based. Patients typically need to be in active care or within a limited post-treatment time frame. Again, funding for medical expense assistance is there in some cases. There are national charities for families with pediatric cancer patients. And there are also monies for special populations, musicians, visual artists, actors, flight attendants, registered nurses, truck drivers, federal employees, firefighters. So there are monies out there to help patients in need. It just takes a bit of digging, and there's an assessment that we do over the phone or in person with patients at the foundation and here at LiveStrong. So feel free to contact us, and we can try to locate those resources for you. Okay, so going over copay relief, this is a program that our foundation offers directly, And it can help insured patients, those who are privately insured and those on Medicare, and then some folks on Medicaid who have out-of-pocket costs. And this is exclusively for co-payments associated with your treatment. It could be chemotherapy, it could be hormone suppressive therapy, it could be pain medication, medications prescribed for nausea and vomiting. Those sorts of expenses we can cover directly, and we'll go into kind of what the process is and how to apply. So you can apply as a patient, and you can also have your physician's office apply on your behalf, and also the pharmacy can apply. And we have a very secure, very simple portal on our website that can walk you through the process. The documents that we need from you are you can scan and upload to us. We've tried to streamline the process and make it easier and quicker to approve you. And then when approval is made, payments are made directly to the doctor's office, to the pharmacy, or are reimbursed back to your pocket. Now, this is the only program that I know of that has a 12-month look-back period. So let's say you were undergoing chemotherapy back in October of last year. This will address expenses you've already paid or expenses you have not been able to address that are still owed to the oncology office, for example. And here are the disease funds that we have currently. You'll see breast cancer, colon cancer, some of the very common cancers are represented. Some of the newer funds that we have are around hormone suppression therapy that might apply for cancers such as prostate, breast, ovarian, and other cancers, and also non-muscle invasive bladder cancer, which represents about 70% of those kinds of newly diagnosed bladder cancers. We also have funds for osteoporosis, for generalized pain, whether it be cancer-related pain or any other kind of pain medication you've been prescribed, and rheumatoid arthritis. And this is a publication that the foundation has put together for the underinsured, specifically to address the needs of the underinsured. You can I'll direct you to our link there, and I also, for the local audience, have a take-home packet for you that you can take away with you. So it's basically a number of pull-out cards that, depending on the situation you're in, and these are folks, again, who are fully insured, it'll give you tips on how to manage it, how to get around it, how to cope with it. There are issues around COBRA, around how to afford COBRA premiums. There are issues around how to afford medications, how to manage those costs. There are issues around limited benefit plans. This is an issue that comes up quite often. A patient will come into my office and they'll say, well, I have insurance, but it's not a major medical plan. My doctor tells me it won't cover my outpatient chemotherapy. What do I do? So this will give you tips as to how to, what alternative options might be available, and how to manage that issue. There's a card on out-of-network issues, insurance denials that I touched on earlier, and out-of-pocket costs and cap benefits. Okay, so I wanted to take time now to kind of give us a mental recess, so to speak, and play a short video. We're going to go into healthcare reform in the next third of the presentation. I just wanted to show a short video to kind of give you an idea, dispel any myths about the reform, clear up confusion, and this should kind of give us something to talk about through the remainder and then through the Q&A session. Now, these changes that are being made are subject to a Supreme Court decision I want to let you all know that decision should be made by the end of June. So fingers crossed, let's hope this is all in place by the time June comes around.
Let's face it, folks, the new healthcare reform law is complex. It runs about 1,000 pages, even in tiny print, so it's no surprise that very few Americans have actually read it. But it's about to affect all of us, and many have been wondering what it will mean for our health, our wallets, and our country. Let's say we take all 310 million Americans and squish us down to just 25 people. Yep, each of these folks would represent about 12 million of us, and this is pretty much what we'd look like. Polls show about 3 out of 10 of us say healthcare reform will make us better off. A similar number say worse off. And a similar number again say it won't make much difference at all. Some of us don't know what to think. I guess you could say we're kind of split on this one. But no matter where you stand on the issue, it's likely you're thinking, hello, I got some basic questions still unanswered here. And you deserve real answers, not the partisan rhetoric and spin we've been flooded with. So let's break down what the reform law does and doesn't do and what it will cost. If you want to read the whole law, go ahead, but watching this video is the next best thing. Ready to jump in? Let's begin with the problems in our current healthcare system. Problem number one is what problem number one usually is: money. Most people agree that health insurance policies are too expensive. For a family, the average premium is almost $14,000 a year and growing. Premiums have doubled over the last 9 years, ballooning way faster than inflation. Plus, our population is aging, meaning more people with more health problems. So healthcare costs are the fastest growing part of the federal budget. The second problem is that the system is full of holes, like the fact that people buying insurance on their own can be turned down for having a pre-existing health condition. Small businesses may be charged extra if some of the workers are sick, making insurance unaffordable. And some insurance policies have a lifetime limit on benefits. After that, you're out of luck. That means some of the people least likely to have coverage are the ones who need it most. Nice, huh? High costs and holes in the system mean more than 1 in 7 of us have no health insurance to protect us at all. Many more struggle to pay their bills and can only afford bare minimum policies that may not cover much. High cost to households, strain on the federal budget, and people with no protection. It's easy to see why many people were looking for something different. So here's what the health reform law plans to do in its first phase between now and 2014. To start dealing with cost, insurers will be limited in how they spend our premium dollars. If they use too much for administrative cost or profits, they'll be forced to give some of it back through rebates. This won't stop premium increases, but it may help some. Some services will become free in all new private insurance policies and in Medicare, preventive care like screenings and vaccinations. People on Medicare, because they're over 65 or disabled, will get more help with their drug cost. Young people can save money and stay insured by remaining on their parents' policies up to age 26. And some small businesses will get tax breaks to help them pay for health insurance for their workers. And the holes, well, some will be closed starting now, too. Lifetime limits on health coverage will be gone, whether you buy your insurance on your own or get it from your employer. And it will be illegal to turn kids down for having a pre-existing health condition like asthma or diabetes. Of course, some adults who buy insurance on their own will still be getting rejected between now and 2014. Those who do can enter something called a high-risk pool run by the government. No, it's more like a policy that covers the sickest uninsured people, meaning it's riskier for insurance companies. That's why the government will chip in some money to bring down the cost. Some say these high-risk pools will help a lot of people. Others say the pools will still be too expensive and may not have enough government money to stay in business until they're replaced by something better in Phase 2. On New Year's Day 2014, some big changes kick in. First, let's look at how the law makes healthcare more affordable. Medicaid will be expanded to cover all low-income individuals and families in every state. And depending on what you make, if you lose your job or your employer doesn't provide decent coverage, you may get a health insurance tax credit. And while most of us will continue to get health insurance at work, just like now, if you don't have that option, you'll be able to buy coverage in what's called an exchange. You'll be hearing a lot about them, so let's stop and look at how they work. An exchange is like a virtual insurance mega mall. Based on where you live, you'll get an easy-to-understand menu of options to compare plans in plain English, and the exchange makes sure insurance companies compete fairly under strict rules. The idea is that by giving consumers good information, a fair playing field, and access to lots of choices, competition among insurers will keep rates competitive. Now, on to plugging the holes. In 2014, insurers will no longer be able to turn people down or charge them more if they're sick. You might say, hold on a minute, if I can't be turned down or charged more, why not just wait until I get sick or injured to buy insurance at all? Not so fast, buddy. See, with few exceptions, people will be required to have insurance or pay a special tax. Same with larger businesses, who will pay fines if they don't insure their workers. Of course, nobody likes being told they have to buy anything, but without this rule, experts say you can't require that everyone be eligible for coverage. Imagine telling home insurers they have to cover people whose houses are already on fire. So the government will provide credits, expanded programs, and new rules. They say that by 2019, 32 million of us who don't have health insurance will have it. Some of those who will still be uninsured, undocumented immigrants who aren't eligible for coverage under the law. No surprise, all this is going to cost money, $938 billion over the next 10 years, according to the Congressional Budget Office, the impartial referee when Congress debates these kinds of things. It's a lot of money, sure, but if you look at it another way, it's 2% of our federal budget and 3% of what we'll be spending on health care overall. Now, the President and Congress insisted these new costs will be paid for so they don't push the budget deficit up any further. That means money will come out of someone's pocket. That's where the tough politics come in. A lot of savings will come from health care providers and insurers in the Medicare program. The fees the government pays to hospitals under Medicare won't be allowed to rise as fast as they have been. And insurance companies that provide services to people on Medicare will be paid less. Medicare will also create a bunch of experiments around the country to test different ways of paying doctors, hospitals, and other providers to make the healthcare system more efficient and improve the quality of care. With luck, some of these experiments will work and then be adopted by the private sector and help lower costs for employers and families, too. Plus, a new federal advisory board will make recommendations about other ways to deal with increases in healthcare costs. Some taxes will go up, too. People with high earnings will pay higher Medicare taxes. There'll be new taxes on insurers and businesses who offer high-end benefit plans and on companies that make medical devices and drugs. And, anyone who visits a tanning salon now has to pay a new tax, too. With these new cost-cutting measures and new taxes, the Congressional Budget Office says the whole package will actually reduce the federal deficit over the next 10 years. Of course, the total federal deficit is expected to run into the trillions, so the health reform law isn't going to solve that problem. Well, that's the reform law. Do you love it? Hate it? Still don't know? Either way, there's still a lot of work ahead. You'll be hearing lots of different things about this law. Some people support reform and, if anything, want to expand it and increase government oversight of insurers in the healthcare industry. Others oppose it and think it creates too big a role for the government. Some states have even gone to court claiming the requirement that everyone buy insurance is unconstitutional. Politicians and pundits will be talking to you as if you've got no idea what's in that 1,000-page law. But by watching this, you're on your way to getting informed, and you can make sure your friends and family are too, just by passing this little video around.
Great, so I wanted to show that video, and because I'm quite a proponent of some of the changes that are rolling out for healthcare reform. Now, the constitutionality of these changes is subject to a Supreme Court decision, like I mentioned, that should be made hopefully by June. So we're going to hold fast to these changes, and I wanted to kind of go over a few of them that are in effect now and how they can really and tangibly help you here locally and those of you viewing at home. I just wanted to show you this map to start. it projects the percentages for uninsured adults ages 19 to 64 here in the States. The total uninsured in the U.S. is at 19.5%, and for the local residents here, Texas is at about 30%, and even here in the Austin metro area at 27. So there's a real need to push these kinds of provisions and to have an understanding and to value them as feasible options. And when we have insurance, we have access to care. It's ready access. They had mentioned that there were a couple insurance provisions that are called risk pools. There was the person with the inner tube and the sharks circling him in the video. I wanted to go over the couple different options that are available to you now. So when you're diagnosed with a qualifying condition, a high-cost condition, you are eligible to opt into either a state-issued risk pool, and that's not available in all states. It is available here in Texas, and we'll go into that a little bit further. And also, there's a federal option, which is a far more reasonable option for folks to opt into. And these are comprehensive insurance plans that, with their own criteria, for example, the federal plan requires that the patient be uninsured for 6 months prior to enrollment, and that includes Medicaid. But I've already seen in the last month probably a dozen individuals for which this was really a perfect option to speed up access to care. We've got them enrolled in this plan. We've communicated this enrollment to their oncology office, and they were able to start treatment as soon as the effective date was set. So I want to stress that this is a viable option for folks, especially in those states such as Texas, where the premiums are being supported or subsidized by the federal government. And this kind of gives you an idea of where in the country these options are available. Every state, with the exception of Nevada, Arizona, Georgia, Virginia, and some New England states, had previously offered a state risk pool plan, if that makes sense, and now are being asked to offer the federal option as well. So here in Texas, later on in the slides, we'll let you know how affordable this plan really is, how you can kind of figure it into your budget if possible, how feasible this option is for folks who are uninsured and with high-risk conditions. And so here is the PSIP, or pre-existing condition insurance plan. Here in Texas, you'll see kind of a chart of the premiums available. So for example, let's say you're a 38-year-old female who is diagnosed with a recurrence of thyroid cancer. Let's give that example. You were insured during your first occurrence, but now you have no insurance. Perhaps you're unemployed. Perhaps you're in the job market searching for employment and thus benefits. The standard option is $239, which is about what it amounts to leasing a car. So I'm not going to say that this is feasible for everyone, but I want to kind of stress this as a value and as an option for those folks who would otherwise have to rely on a very overbooked county medical system or charity system in their town or city. This will give you ready access to the care that you need. It's commonly accepted by providers nationwide, and it's a very good option. And then looking forward, you saw a little bit in the video projecting forward to 2014. There will be an exchange, and it's going to be really an opportunity, and in fact, I believe we'll all be encouraged or perhaps forced to opt into an insurance plan, and we're going to have various options. Small employers will be incentivized to offer this kind of coverage. So if you happen to work for the mom and pop diner down the street, or for a small retail business, for example, you should be able to get coverage starting January 1st of 2014. Also, there will be premium subsidies, so that those folks who fall under a certain poverty level will be able to benefit from a partial subsidy, making it kind of feasible and something they can value and incorporate in their budget and maintain. And also, you saw in the video that they're going to expand the Medicaid program, accommodating more people, and so that's a very positive thing. This was a little website that a Patient Advocate Foundation started up called insureustoday.org. You can visit it. It's a collaborative effort of healthcare stakeholders across the spectrum to allow the patient to understand these changes and to clarify confusion. And it's kind of a timeline, so it lets you know what changes are being implemented in 2012, 13, 14, all the way up to 2020. And I believe there's a handout that we've sent electronically to those viewing at home, and a handout here for the local audience that you can have a look at. And really, that's the end of the presentation. I put some information on the screen. This is the contact information for our foundation and for our copay relief program, if you'd like to contact them directly. I work, as I said, here in Austin, Texas, with the LiveStrong family. And so you can feel free to email me, and we can get that information to you. Thanks so much for attending here locally and at home, and I really appreciate it. Hope you learned a bit. Okay, so for the Q&A session, I thought that those folks who are attending here locally, if you have a question you'd like to ask, that you'd step up to this microphone here in the foreground, and then we'll alternate between those questions that come up here locally and those questions that come up from the folks at home. So, anyone have a question at all? Steve, yeah, go ahead.
Well, my question requires that I tell you a little bit about my situation. So,
Feel free.
I have, on the end of December, a non-small cell lung cancer diagnosis. I got the Social Security disability almost immediately. You wait 5 months before there's a payment, the first payment for that. And in my situation, the Social Security disability will be about $36,000 a year. When I pay my health insurance premiums and all of my out-of-pockets and everything that I'm required for, that's about $15,000 a year. And so I have 2 children, and they're 7 and 8 years old. I'm an old guy, but that's what I have. So when you start doing the math, and it's difficult for me to work now. The nature of the work I do requires contracts to be written and high stakes for people. And when I'm on the medication, the chemo or the blockers or whatever it is, my brain doesn't work well enough to maintain those things. And so I find myself in this situation where I don't seem to be eligible for much of anything. And if I could find help with paying the insurance premiums, or, I mean, what about someone in my situation where you're sort of in the middle? It's not that I don't have any resources, but if the way this is going, by the time I pay mortgages and by the time I buy groceries and by the time I do everything else, it's not going to work.
Well, thanks, Steve. And this is a really common concern, and it's not a difficult one to address. There are lots of folks who are in that low to moderate income bracket, and the system just isn't accommodating them, or resources are slim or scarce. And really, I have to be frank that there are limited resources to assist you with that health insurance premium. However, they're there. And it takes kind of a strategy of calling around and piecemealing money together to cover those premiums. Now, if one, God forbid, should have to go without insurance because it's not, it's a hardship on the family, and you just have other priorities that are higher, that are more valuable. I would have to say that certain services, certain medical care in that situation can be obtained through some of the safety nets and programs that we introduced earlier. I never want to encourage or suggest that a patient abandon their insurance because they can't make the premium. It's, however, it's kind of a part of this whole cancer reality. So if you're having, if you feel that you need to, or if it's just happened that you're without insurance, definitely contact a caseworker. There may be some creative strategies that we can get you, pharmaceuticals that you've been recommended that you would not have to pay otherwise, that we can negotiate self-pay discounts with providers, with physicians, with specialists, negotiate lower rates on diagnostic testing that you need to follow up for your cancer. And also for families, there are quite a few resources out there, and for those who have minor children or who have large families, we can develop a compelling case and look for that help, look for those resources for you. Any other questions from here locally or at home?
I have a question from an at-home viewer.
Okay.
Are there any specific resources for college scholarships or any other types of scholarships for school?
Well, there are. The question was, are there resources for college scholarships? And there are. It's quite a long list, and it depends on the area of the world where you live. It depends on your age. They might require that you yourself be a survivor, a young adult survivor of cancer, or that you have a parent who has survived or passed from cancer. So this is a list that I keep handy, and I always filter through depending on the need, depending on the situation. And for those of you viewing at home, if you're looking for this such a list, we can get that to you at a later time. Go ahead, Rose.
I have a second part to that question. When my son was diagnosed, he was in the fall of his junior year. So the monies that we had paid in to college, we lost because we had to withdraw him. Is there any sort of help for that type of situation? They did offer freshman year an insurance that we never thought we would need. So that was something that I knew was out there, but didn't do it.
Okay.
Freshman year.
Are you concerned, Rose, more with insurance, maintaining insurance for your son?
Well, he's going to be going back to school
Okay.
This fall, so tuition is high, and you know we're working on scholarships right now, but that chunk of money, he's still having to pay the loans back. The loans started right after he was diagnosed. He had to quit, so as soon as you quit college, you have to start paying on the loans.
Mm-hmm.
So even though he got, I mean, it's just like so we're paying on something that he never received, I guess.
Sure, I understand. Well, there are options, and I know this firsthand, that you can defer a student loan. You can make arrangements with the bearer of the loan, and also, like we had mentioned earlier, scholarships that are available. Those may apply to loans that are still owed. They may apply directly to tuition expenses, room and board, that kind of thing. So definitely, as a case manager, whenever I get that question, I always look through my list and identify those that I really feel are viable, really feel that suit the patient, depending on his or her age, athletic interests, etc. So, and I've even written letters of recommendation, so feel free to contact me and we can kind of talk it over.
Okay, and I have a second part. He is receiving SSI or Medicaid, but I'm not really sure who to contact, because once he becomes a full-time student, does that mean that he will no longer have that benefit? I mean, he's still he's still leukemia, and he's still, has that diagnosis.
No. Actually, one of the provisions in the law allows a recent graduate from college or anyone, a young person up to the age of 26, to be enrolled in their parents' policy. It's a provision that is helping countless upon countless of youth. So that's an option. Once that person ages out of Medicaid, the option to either apply for Medicaid as an adult or to enroll in their parents' policy. Those are options available.
So that what he has right now shouldn't stop because he's going to be a full-time student?
If he has a private insurance or employer sponsored, it should not. It should not stop. Before this healthcare reform rolled out, the day that he graduated from college and was not able to get into a full-time employment position with benefits, he would have lost his insurance. But now he does. There is that safety net.
Okay.
Yeah.
Okay. Thank you.
I have another question from an online viewer. Is premium assistance available for someone who had a recurrence a year ago and then developed a life-threatening neurological condition as a paraneoplastic disorder? It's very specific, but I wonder if you could talk to the premium assistance availability.
Okay. Well, premium assistance, and again, I hate to say this, frankly, but it's not readily available. Now, however, with that said, it doesn't always require that the patient be in active treatment, so you can be in a post-treatment phase or suffering perhaps with some of the latent side effects of treatment, like Emily had mentioned, or the person from home had mentioned. It largely depends on the diagnosis alone and whether or not there is a regional charity in Seattle, Washington, or Austin, Texas, or New York, or some sort of cancer organization that has funds available for it. And so it's a matter of calling around. I'll spend countless hours calling and emailing just to secure that little bit of money that's going to help a patient maintain their insurance. So in a general sense, that's kind of the answer. Any other questions? At home or locally? No? Well, thanks so much for coming out. I really appreciate it. I hope you learned a little bit, and feel free to come to me with any real specific scenarios, and we can talk through them. Thanks.